Hi, y'all, and welcome back to Professor Truelove's Concepts for Nurses series. And in this episode, we continue our neurological concepts, specifically with spinal cord problems. And this will be part 2. Sources for this episode include Higgie's Medical Surgical Nursing 9th edition and Soul's Introduction to Critical Care Nursing 7th edition. It is important to remember to differentiate spinal shock from an actual injury. Spinal shock, or spinal shock syndrome, occurs immediately as a concussion response to the injury, resulting in flaccid paralysis and loss of reflex activity. Spinal shock usually resolves within 24 hours, and muscle spasticity begins in patients with cervical or high thoracic injuries. You should perform a detailed assessment of the patient's motor and sensory status to assist in determining the level of injury and to serve as a baseline data for future comparison. For the spinal cord injury initial assessment, make sure that your priority is airway, breathing patterns, and circulations. Double check your level of consciousness using your Glasgow Coma Scale. Look for indications of intra-abdominal hemorrhage or hemorrhage bleeding around fracture sites, and look at the level of injury, including tetraplegia, quadriparesis, paraplegia, and paraparesis. Assessments should include checking for cardiovascular dysfunction from disruption of the autonomic nervous system, which results in bradycardia, hypotension, and hypothermia, and this can lead to cardiac dysrhythmias. Remember that a patient with a cervical SCI is at risk for breathing problems resulting from reduced mobility or from an interruption of spinal intervention from the respiratory muscles. Assess the abdomen for indications of hemorrhage, distension, or paralytic ileus, and assess for skin issue integrity with each turn or repositioning. Your plan of care should include musculoskeletal concerns, because muscle wasting results from the long-term flaccid paralysis seen in patients with lower motor neuron lesions. And an incomplete lesion or upper motor neuron lesion may cause muscle spasticity, which can lead to contractures after the neurogenic shock has been resolved. For psychosocial concerns, remember that the patient with an SCI must cope with changes in body image, self-esteem, independence, role relationships, and sexuality. In addition, assess family members or significant others to determine how well they are coping with the patient's injury and their role changes, because patients must be prepared for extreme rehabilitation and lifestyle changes. Prioritizing management of spinal cord injury starts off with non-surgical management, including airway management, that is, assessment of respiratory function to optimize pulmonary functioning, maintaining positioning and immobilization where necessary, maintaining cardiovascular stability, including drug therapy if needed. To maintain spinal cord perfusion, you need to maintain a mean arterial pressure between 85 and 90 millimeters of mercury. Your drug therapy should consider deep vein thrombosis prophylaxis. Surgical management may be indicated depending on the extent of the injury. Before that happens, consider gastric decompression in order to prevent autonomic dysreflexia. And lastly, do introduce the patient and their family to the various community resources available. Priority for long-term care continues to be skin care and elimination. For spinal cord injury medical management, consider spinal cord stabilization using something like a halo vest or surgical intervention with the placement of plates, rods, or even bone grafts. Medications included, but not limited to, glucocorticosteroids, including high doses for reduction of inflammation, vasopressors and fluids for cardiovascular support, proton pump inhibitors for prophylaxis for stress ulcers, and IV fluids for both renal and cardiovascular support. Priority problems for long-term management include monitoring for difficulty breathing, impaired physical mobility, safety that is, spastic or flaccid bladder and bowel, and of course, impaired adjustment. An emergent complication associated with spinal cord injury is known as autonomic dysreflexia. Autonomic dysreflexia occurs at T6 or above after a resolution of spinal shock. It is an intense sympathetic response to stimuli, normally caused by kinked urinary catheters or fecal impaction. This leads to severe hypertension, headache, and bradycardia. The treatment is to assess and remove the cause. So, typical physical assessment findings for the person with spinal cord problems include flexor spasms at night, an intention tremor, dysmetria, blurred vision, diplopia, decreased visual activity, scotomas, and nystagmus, hypalgia, numbness, tingling or burning, and bowel or bladder dysfunctions can all be symptoms associated with the different spinal cord injuries. Because of the significant changes that occur with spinal cord injury, a psychosocial assessment is tantamount, and not only with the patient, but with their significant others or family. Laboratory assessments can help us scout for complications from the spinal cord injury, including but not limited to things like liver function and renal function tests, or even other diagnostic tests to determine how other systems of the patient is functioning, such as pulmonary function testing and electrocardiography. Although current therapies are all directed at either reducing or stopping the deterioration of neurological function, there still is research moving forward into trying to even reverse the damage of a spinal cord injury. And some of these new therapies range from interferon beta all the way to IVIG. IVIG is also called gamma globulin or antibodies. This is a highly purified blood product, preparation that is derived from large pools of plasma donors. Besides trying to reverse the injury using futuristic type drugs, it is important to remember that there is drug therapy in the here and now. And these drugs include a muscle relaxant for comfort and positioning to prevent things such as contractures, treatment of the paresthesias, which are the unpleasant tinglings, and treatment of bladder dysfunction. Other interventions include promoting mobility, managing the symptoms associated with the spinal cord injury, and of course, complementary and alternative therapies to promote acceptance, relaxation, and a reduction of stress. When caring for a patient with a spinal cord injury, it is important that you determine how long they've been suffering from this disability. You will know if you're taking care of the patient during a trauma, but these patients are subject to many complications. An important question is, how long have you been suffering from spinal cord injury? Continue your physical assessment looking for clinical manifestations of either short or long-term results of spinal cord injury. And remember that fatigue is frequently an adverse effect of SCI. Just a brief mention about spinal cord tumors. And the reason they're here is because no matter what the injury is to the spinal column, the manifestations are going to be very similar. So therefore, a spinal cord tumor, even though it normally doesn't happen because of something like an injury that is trauma, it is still going to have the same ramifications. So there's different types of spinal cord tumors. They include primary, intramedullary, and extramedullary, that is the location of the spinal cord. As far as the assessment findings are going to be very similar, that is, based on the level of an injury, you're going to also have deficits based on the level of the spinal cord tumor. So your priority problems with interventions is going to be surgical management, even emergency surgery, if these tumors are impinging on the respiratory or cardiovascular centers. Non-surgical management includes radiation and chemotherapy. And that does conclude this episode of Neuro Concepts. Tune in soon. There will be a subsequent episode. And we'll see you then.